Dear friends, this is my first online class on inguinal hernia. We are living in COVID era. We are compelled to have online classes for our subjects. So we have started our online teaching for our undergraduate students. This lecture on inguinal hernia will be very useful for all the MBBS students for their exams.
So today's topic, as I told you, it was it's inguinal hernia, and what we are going to see as different headlines when you come to clinical side is anatomy, clinical examination, pathophysiology, types of hernia, management of hernia, rare types of hernia, incisional hernia, exam corner, and MCQs. This is the way you will look at it when you move to the next year. But today, don't get worried, I am not going to talk so much all these things. We will we will confine ourselves to anatomy and pathophysiology, because the basic sciences are one which you are now getting well versed with, like anatomy, physiology, biochemistry. Understand? Your altered anatomy, altered physiology, and altered biochemistry are going to be the clinical diseases or clinical subjects which you are going to see later. So today we will confine ourselves to altered anatomy, physiology, and biochemistry of inguinal hernia. Before going into any topic, always definition is important. So, have you heard of hernia first? Hernia, have you heard of?
Yes, sir.
Yes, sir.
What do you mean by hernia? Any one of you?
Protrusion of the intestinal contents due to weakness of the abdominal wall.
Very good, very good. So, the definition is hernia is an abnormal protrusion, not, you said protrusion. It is not normal protrusion. It is abnormal protrusion of abdominal viscus through an abnormal opening in abdominal wall. This is the definition of hernia. You can easily remember this because of this four A's. Abnormal protrusion of abdominal viscus through an abnormal opening in abdominal wall. In this picture you can see abdominal viscus, that is intestine, coming through the internal ring and then through the external ring and bulging out. This is what is hernia. Now, since it is inguinal hernia, you should know about the inguinal region. Let me tell you what is inguinal region. Inguinal region extends from anterior superior iliac spine to pubic symphysis, and the layers of the lateral abdominal wall, they are continuous over the inguinal region also. So this is a diagrammatic representation. Little amount of surface anatomy which you already know, I will try to recollect here. You can see the symphysis pubis. This is your anterior superior iliac spine, and the line which is joining these two is called inguinal ligament, and at the level of mid-inguinal point, you have got deep inguinal ring. Mid-inguinal point is the point between anterior superior iliac spine and symphysis pubis. So here is the deep ring, and then near the pubis you have got superficial inguinal ring. And the canal which is connecting these two rings is called inguinal canal. Before going to inguinal canal, let us see the structures which are there in the inguinal region. This you must be all knowing, understand? Actually, I am repeating what your anatomy department has told you. Still, recollection of this is very important to understand the clinical side. So, I again insist upon the basic sciences, basic departments, anatomy, physiology, and biochemistry are crucial in your life. So, you should have a thorough knowledge of it to understand the clinical medicine. Anyway, the layers are skin, subcutaneous tissue. In subcutaneous tissue, you have two layers, superficial fatty layer that is called the campus fascia, and deep membranous layer that is called carpus fascia. Then external oblique muscle and aponeurosis, internal oblique muscle and aponeurosis, transversus abdominis muscle, transversalis fascia, extraperitoneal space, and peritoneum. These are the layers from superficial to deep. Here one point which is coming recently is, this is regular anatomy which you are taught about, and of course they would have told about laparoscopic anatomy also. Laparoscopy is reverse. Through umbilicals, you put the laparoscope in, you are seeing the structures from behind to forward, from posterior to anterior. You start seeing peritoneum, then extraperitoneal space. That is very important in the management of laparoscopic hernia recti. Now we will get back to inguinal canal. Inguinal canal is a slit-like passage that extends downwards and medially, above and parallel to lower half of inguinal ligament. That you would have known already. It begins at the deep inguinal ring, ends at superficial inguinal ring. Length is about 3.75 centimeter. In infants, superficial and deep inguinal rings are superimposed, and obliquity is slight. With growth in size of the pelvis, deep ring gradually shifts lateral to form the inguinal canal. Now the inguinal rings. The first one is deep inguinal ring. It's a oval opening in the fascia transversalis, 1.25 centimeter above the mid-inguinal point. What is that mid-inguinal point? Midpoint between anterior superior iliac spine and pubic symphysis. It lies above the inguinal ligament and lateral to inferior epigastric artery. It is the beginning of tubular invagination of transversalis fascia, which forms the coverings of the spermatic cord. It forms the transversalis fascia sling with superior and inferior crura around the deep ring. Then superficial inguinal ring. It's a triangular opening in the external oblique aponeurosis, situated above and lateral to pubic tubercle. It has medial and lateral crest. Lateral crest is attached to pubic crest. Medial crest is attached to pubic tubercle. Some fibers arch over the crura to form intercrural fibers, which prevent the crura from spreading apart. When the external oblique contracts, these intercrural fibers close the external ring. It is called a slit mechanism. That we will see later. What are the boundaries of the inguinal canal? Anteriorly, external oblique aponeurosis and origin of internal oblique in lateral 1/3. Posteriorly, transversalis fascia, medially by conjoint tendon. Roof is formed by arched fibers of the internal oblique. Floor is formed by the grooved upper surface of the inguinal ring. And what are the contents? In male, spermatic cord and its coverings and ilioinguinal nerve. In female, round ligament of uterus and ilioinguinal nerve. These are the basic anatomical points regarding inguinal hernia. Now this is a diagrammatic representation. I feel you will get a feel of a blackboard. That's why I have given this diagram. The external oblique muscle is removed and you are seeing just behind what it is. Internal oblique you can see, and that arches around the inguinal canal go medially, combined with transversalis fascia to form conjoint tendon. This is the pubic symphysis, and the blue line indicates transversalis fascia, and the inguinal ring is there here in the mid-inguinal point. This is anterior superior iliac spine. I think you people have recollected your anatomy by this time. I don't think you will be like this. Have you been following this anatomy so far? Having seen this anatomy, there are a lot of mechanisms, physiological mechanisms, which prevent hernia formation. That we should go through. And common etiological and precipitating factors are there for hernia, then specific factors for indirect inguinal hernia and direct inguinal hernia. Now I will see the common one. One, increased abdominal pressure. Increased intra-abdominal pressure forces the abdominal contents to pass through a preformed sac or weakened abdominal wall, resulting in hernia. You understand? We saw so much about anatomy. Where there is a weakened abdominal wall or a preformed sac, the increased intra-abdominal pressure will result in hernia. What are the common causes which causes increase in the intra-abdominal pressure? One, chronic cough. Two, difficulty in micturition. In old age, people develop prostatic enlargement, which will result in difficulty in micturition, and also they develop weakness of the muscle. So very common, the direct inguinal hernia is in the old age. Next is constipation, almost same mechanism. Strenuous work, lifting heavy weights, will result in strain on the muscles that may result in hernia. And rarely intra-abdominal swelling, maybe malignancy or any other swelling that can cause hernia. Next is smoking. Smoking, all of you know, chronic smoking results in COPD, that is chronic obstructive pulmonary disease. It gives chronic cough. So going on coughing will increase the intra-abdominal pressure and that will result in hernia. That is a mechanical force. But many people think that is the only cause. No, smoking can also cause acquired collagen disease deficiency that cause weakness of the abdominal muscle by various altered biochemical reasons. You can get acquired collagen deficiency, which will result in the weakness of the mind to ask people not to smoke hereafter. Then another common cause is obesity. In obese individuals, fat infiltrates the muscle bundles, causing weakness in the abdominal muscle. Understand? Because of the infiltration of the fat between the muscle fibers, the muscles naturally become weak, and obesity people are more prone for hernia formation. These are common causes for hernia. There are specific pathophysiology, you understand, for indirect inguinal hernia, direct inguinal hernia, and femoral hernia. Here we are going to see about indirect and direct inguinal hernias, where what are the specific pathophysiology. This is indirect inguinal hernia. It is the most common type of hernia in which contents comes out through deep inguinal ring, passes through inguinal canal, enters the scrotum via superficial inguinal ring. You recollect that first slide which I showed you, where the hernia, that is abdominal content, enters through the deep inguinal ring, goes through the inguinal canal and enters the scrotum via superficial inguinal ring. They are almost always congenital. There are normal mechanisms that prevents the herniation of these contents. These abdominal contents, they are blocked by normal mechanisms that we will see hereafter. But before that, I will tell you about the development of this congenital hernia. During descent of the testis, a pouch of peritoneum descends through inguinal canal into the scrotum, and it is called what? You would have heard it. What is it called?
This is vagina.
This is vagina.
Very good. PV sac or processus vaginalis. Understand? If the processus vaginalis is patterned, it may act as a preformed sac into which abdominal contents radiated. So normally there should be obliteration of the processus vaginalis. Am I right?
Yes.
If it is not obliterated, the sac will continue to be there and it will result in hernia. This may be the reason why hernia is more common. And right side it is more common because it is attributed to late descent of right testis. That's why right-sided hernias are more common. So if it is persistent, it is called congenital hernia. But once it is obliterated, still hernia can happen. And what are the mechanisms which will prevent hernia formation? Or normal protective mechanisms. One, superficial ring. It is guarded by conjoint tendon. God has created conjoint tendon and reflected part of inguinal ligament to cover the superficial ring. Deep ring is guarded by internal oblique muscle. Understand? It comes from the transversalis fascia, but covered by the internal oblique muscle. And three, obliquity of the canal. It is called flap valve mechanism. Deep and superficial ring don't superimpose and are oblique to each other. If there is increased intra-abdominal pressure, both anterior and posterior walls approximate each other and prevent the contents from herniating. You understand, when there is a cough or any other increased intra-abdominal pressure, both anterior and posterior walls try to approximate, and that will prevent hernia formation. Are you able to understand this mechanism?
Yes, sir.
flat wall. Now shutter mechanism. This is easy for you to understand. You would have seen a lot of shops. They will pull the shutter down to close the shop. Similar mechanism happens here. That's why it's called shutter mechanism. Here you will remember internal oblique forms triple relation to the canal. That is, it forms anterior wall, superior roof, and posterior wall. Contraction of this muscle, along with transverse abdominis, approximate roof of the anal canal to the floor and closing the canal like a shutter. Do you understand what I mean?
Yes.
Yes, sir.
Yeah, the contraction of this internal oblique, which is forming the roof, that will come down to the inguinal ligament, so that the entire inguinal canal will be closed, so that nothing will be able to herniate through that. Then slit valve mechanism, about which I already told you, contraction of the external oblique muscle closes the external inguinal ring like a slit along with intercrural fibers. These fibers will contract and close the external ring. That is called slit valve mechanism. Now the ball valve mechanism. That is due to contraction of the cremaster. Cremaster comes from which muscle? Any idea? Cremaster comes from which muscle in the inguinal canal?
The transverse abdominis and the internal oblique.
Internal oblique, yes. It comes from the internal oblique. Fascia comes from, transversalis. You understand? This contraction of the cremaster muscle helps rheumatic cord and testes to be pulled up and to plug the superficial inguinal ring. You understand? That is what is known as ball valve mechanism, where both testes and cord structures, they are pulled up by the cremaster muscle and they are trying to close the external ring so that hernia cannot form. Now, having seen this anatomical and physiological mechanisms, now hormones, biochemical factors, they also play a protective role. How? It keeps the muscle tone going. It increases the muscle tone, and if the muscle tone is good, most of the time hernias will never happen. So those are the factors regarding indirect hernia, the anatomical and physiological mechanisms and biochemical factors which are helping you to understand. Now we are coming to direct inguinal hernia. In this type, abdominal contents enter directly into inguinal canal through a defect in the posterior wall, mainly through Hasselbalch's triangle. What is this triangle? We will see it later. They are more common in old age. Common etiological factors are any conditions that may weaken abdominal wall results in direct inguinal hernia. I told you about the conditions, we will see that also. And apart from the common factors discussed above, other important factor is age, that is old age, commonly weakens the abdominal muscles. And trauma to the muscle wall, that will also weaken the muscle following some injury or other things. And injury to nerves supplying the muscles, they can cause weakness of the muscle that will result. One specific indication is, a specific area is appendicectomy scar. What is appendicectomy? Anybody?
Removal of appendix.
Yes, exactly, you're right. Appendicectomy is removal of appendix. You will have to do it through, in open surgery, you will have to do it through an incision. That incision is called? Any idea? May not be. Anyway, it is. Hello, yes, come.
McBurn is point incision.
Very good. McBurn is incision or gridiron incision, where you make an incision in the layers which we saw earlier, skin, subcutaneous tissue, and external oblique also is divided. Internal oblique and transversalis are being separated out. They are not cut, but they are separated out. Then we go to the peritoneum open and go for appendix. In this incision, ilioinguinal nerve may be injured. Once you injure the ilioinguinal nerve, the posterior wall of the inguinal canal becomes weak. The muscles forming the posterior wall will become weak and result in hernia. That's why in clinical side, when you are given a hernia case, you are supposed to ask for the history of appendectomy. You are supposed to look for an incision in the abdomen in the McBurney's area. Understand? Which will help you to know that this hernia is due to a nerve injury. Now you know this is the anatomy of Hasselbalch's triangle, and HE is wrong. The spelling E should be A, HASS. So here it is shown as a triangle in the red line, and the medial wall is formed by the lateral border of the rectus abdominis muscle, and the floor or lower border is made by the inguinal ligament, and laterally the inferior epigastric artery forms the lateral limit of the Hasselbalch's triangle. This area becomes weak and hernia tries to come through this directly. So in direct inguinal hernia, the area through which it comes out is called Hasselbalch's triangle. I think now you will be able to correlate between the anatomy and the hernia formation. Am I right? Are you able to understand?
Yes.
Yes, sir.
Have you heard of Hasselbalch's triangle earlier?
Yes. Yes, sir.
Okay, okay. Then, you know, today's world, regular anatomy is not enough. Our anatomy department would also have told you laparoscopic anatomy is equally important. Without understanding laparoscopic anatomy, the abdominal surgery is going to be almost nil. You understand? So you have to learn more of laparoscopic anatomy. Sorry for the spelling mistake. PIC, LAPAROS, COPAC, then anatomy. We will be touching upon laparoscopic anatomy in the anatomy department, but future it is going to take the bulk of anatomy. Now here I would like to tell you about the laparoscopic anatomy, which is needed for inguinal hernia repair. For laparoscopic surgeries, the anterior abdominal wall is viewed from its posterior aspect. We saw the layers from anterior to posterior, but now we have to see it from posterior to anterior. That is in the abdomen, peritoneum, then preperitoneal space are important anatomical elements for preperitoneal hernia attack. So in case, I am going to confine myself to laparoscopic anatomy of inguinal area because it is important in the laparoscopic repair of hernia. In the midline, behind pubis, preperitoneal space is known as space of Retzius, which continues laterally as space of Bogras. So important as Professor of Anatomy has told, this Bogras space is very important, about which they have already talked with you. I think you will have at least a mental idea of what is this Bogras space. I will show you how we enter into the Bogras space in the video which is coming later. And from the posterior side, if you see the abdominal wall, 5 umbilical folds are seen in the peritoneum. Median umbilical fold, which is remnant of urachus. 2 medial umbilical folds, which are obliterated umbilical arteries. And 2 lateral umbilical ligaments, which represent the inferior epigastric artery. Now in this diagram I will show you. This is what is 5 folds. Only one in the midline, that is median umbilical fold. That is a remnant of urachus. That extends from bladder to the umbilicus. Urachus that gets obliterated during development. So that remnant is called median umbilical ligament. We will be able to see through laparoscopy. Medial umbilical fold is obliterated umbilical artery, and lateral umbilical fold is inferior epigastric artery. On either side of the midline, we see all these folds so that we can fix the anatomy of hernia. Now this is a cross section which many times our anatomy people would have told you. Pubis and urinary bladder, in between you have got space of Retzius that extends laterally to Bogras space. So they are continuous space. Actually behind the pubis it is called space of Retzius, and once you go lateral to the inferior epigastric artery which is represented there, it is called Bogras space. Are you able to understand this Bogras space?
Yes, sir. Yes.
Okay. Now let us try to see what is Bogras space. See, this is the peritoneum. Posteriorly, you are seeing the peritoneum that is in the inguinal region. With the 10 mm telescope, I am showing you the backside view of the abdominal wall, and we are opening the peritoneum. You can see the nice loose areolar tissue which is representing the Bogra space. So this is what is Bogra space, and here my marker shows you a fold. That is your medial umbilical fold. Medial umbilical fold. And here represents the bladder, urinary bladder. So if you open here, that is going to be space of Regius. And lateral to this fold, when you open, you get Bogra space. Understand? Now this Bogra space, we will try to dissect more and see the structures which are situated in the Bogra space. This is the dissection with the upper peritoneal fold and lower peritoneal fold, and you are taking it laterally almost up to psoas, and you are seeing all the structures which are situated in the space of Bogras. And this is your defect, direct hernial defect, inguinal hernias defect. This represents the Hasselbalch's triangle. And here is the inferior epigastric artery, and inguinal ligament is lower, and rectus border is on the medial side, and this represents the Hasselbalch's triangle through which hernia has gone in. We have dissected out the hernia, so now we are seeing only the defect. And here is the vas deferens. Here is the testicular vessels. They are joining here. It is the point where your internal ring is formed. So these are the structures which you could clearly see if you go into the Bogra space. That is the advantage of laparoscopy and laparoscopic anatomy. So unless you know this laparoscopic anatomy, it is difficult for us to enter into the Bogra space. So the future will be more for laparoscopic anatomy, and you will be shown many of these structures through laparoscopy. And now what you should do, you have seen the hernial defect, and you have seen all other important vital structures in the inguinal area, and you have to put a mesh and cover the whole thing. So this is how the mesh is placed, and it is covering the whole area, including the hernial defect. Now we have to close this peritoneum over this mesh, and ultimately it will look like this.